AAAs can be tricky to diagnose, so here are some traps for the unwary clinician. Try and make sure that your patient doesn't fall into them. Number 1. Relying on the abdominal examination to rule out a AAA. Only about half of abdominal aortic aneurysms are palpable on exam. If you are in any way concerned, you need to get a scan to rule it out definitively. Number 2. The patient with renal colic that isn't a renal colic. So this is classically the middle-aged male smoker who presents to ED with apparent renal colic but does not have any blood in their urine on dipstick. This patient has a AAA with a contained leak until you prove that they either don't have an aneurysm or they don't have a leak. Trap number 3. Assuming that because they have palpable femoral pulses, they can't have a ruptured AAA. This comes up time and time again. It doesn't really make sense if you think about it. It's perfectly possible to have a huge retroperitoneal hematoma and still have palpable femoral pulses, at least right up to the moment when the patient has a PEA arrest from their hypovolemia. When it comes to imaging, remember that an ultrasound scan will only tell you whether an aneurysm is absent or present. If you need to rule out a contained leak or rupture, you are going to need a contrast-enhanced CT scan. An ultrasound cannot rule out a ruptured aneurysm. Trap number 5. Missing the peripheral aneurysm. Remember that about 10% of AAA patients have a coexistent popliteal aneurysm, and about 5% have a coexistent femoral artery aneurysm. They can be picked up clinically by examination, and it's embarrassing to miss them. So there you have 5 common traps with abdominal aortic aneurysms: relying on palpation to exclude it, the renal colic patient that isn't, being reassured by femoral pulses, trusting the ultrasound to rule out a rupture, and missing the peripheral aneurysm. The revision notes are at vasculartutor.com, and don't forget to like and subscribe. Thanks for watching.